Good evening, ma'am. Thank you so much for taking time to join this meeting. I'm Dr.
Good
Sindhu,
evening.
public health intern with. I'm doing interning with one public health company, and today we are joined by Dr. Aishwarya, who completed her BDS from Amrita School of Dentistry and MDS from Government Dental College, Trivandrum. She has worked as senior resident at Government Dental College, Thrissur, and is currently practicing as a consultant endodontist at Thrissur. Very warm good evening to you, ma'am.
Thank you so much. Good evening. Thanks for having me here.
Thank you. Today we will be discussing endodontic care, pain management, and access to quality dental treatment. Ma'am, with your permission, I would like to record this interview.
Yeah, sure.
Thank you, ma'am. Shall we begin, ma'am?
Yes, we can.
Yes, ma'am. And my first question is, can you briefly describe your current role and experience in endodontics, ma'am?
Yeah, sure. So right now I'm working as a private consultant, but I worked in government sector also. So my post graduation was in government sector, and after that I also worked, as you mentioned, I was a senior resident. So right now, majorly my work and practice is in private sector, largely with consultations and giving sometimes even I give online consultations, but largely I just, and that's it. And sometimes even I take classes like private classes. So that's it for now. I'm just doing this right now.
Great, ma'am. How many patients do you have gone through in your experience, ma'am?
uh, when I was doing post graduation, it was a lot, like, because you can imagine how it would be. And in Trivandrum, we also had a regional cancer center. So, and government medical college also was very nearby. So we had all referral patients from there. So we had medically compromised patients. So there were a lot of patients that we came across in post graduation. Private practice, it depends. I go to almost like 10 clinics. So it depends on the work is, and sometimes if it is like call is more. Otherwise, it is fine because I've been working for more than 2 years in private sector. Slowly, I've been exposed to more private patients. But compared to government, private has been in quantity.
Okay, ma'am. Okay, ma'am. What is the most common case you have came across in your practice, ma'am? In endodontist, what is the most commonly recurrent case you have seen, ma'am?
Recurrent, usually
Condition.
people come with pain. That's how we go for this endodontic treatments. Other than that, like since my practice also has conservative dentistry in it, a lot of anterior restorations, even posterior aesthetic restorations come to me while I practice. But largely, when it is just focused on endodontics, it's largely with pain. So mostly it is symptomatic irreversible pulpitis, or even retreatment, like where patient has already undergone a treatment before and they come back with pain or swelling in that area. And non-vital also comes, but usually it is the pain because people come when they have pain to an endodontist. So that's how it is.
Toothache is the most common pain, and a patient can't able to manage that.
Yes, true. Because usually they would take one course of antibiotic. They know that they'll have to take antibiotics and painkillers, and despite that, when they have pain, they come to us, and that's when usually that is also a problem for us because we encounter a lot of hot teeth. It's difficult to anesthetize those teeth. It takes a lot of time. Even the patients are in a lot of pain. So even hot teeth is also something I'm commonly encountering in practice. Especially these, most of them, they keep taking antibiotics and painkillers and they prolong this period of infection. And when they come back, it's not manageable in the first appointment.
Okay, ma'am. From your perspective, what is the key prevention strategies we can make to prevent such conditions, ma'am?
Usually, first is patient education, like how much ever we can to educate them to come at least regularly for visits. And just do the general dental checkup. I think I don't know if it is because of the area I'm practicing. There is that general fear to come to a dental clinic and get their teeth checked. They always feel what we'll tell an expensive treatment, and they have that fear. So I think we should give that awareness, talk to them, and not force them into doing anything, and make them take their own decisions. And even from our end, we have to make sure the patient comes, like even though they come for scalings, tell them if there is any demineralizations, that even without fillings there are there are protocols that can be followed. Even just remineralization paste can be given, so those are all not invasive. So I think the basic thing would be patient education, and also for us dentists to be aware of what are the preventable diseases and how to manage them without any interventions. There are so many methods we can follow. So I think that is the key thing, especially when it comes to prevention.
Okay, ma'am. Thank you, ma'am. And what are the effective current diagnostic? So recent days we are having more of AI and technology advancement. What are the advancement in diagnosing these endodontic cases, and also how you are managing and treating such cases, ma'am?
Because largely, practically speaking, I think CBCT has been a very big advancement and very useful. There are other advancements also, but for us to use it clinically and practically also, it's not feasible. Sometimes it will be very expensive. Even CBCT, it is an expensive, this diagnostic tool. But when once we feel that that treatment or that tooth has some kind of complexity in it, most of the patients are ready to go for CBCTs when we tell about the complexities. There is some morphological changes, or especially from the management end, from our end to treat endodontically. CBCT has been very helpful. Other than that, the normal basic things is itself sufficient, is what I feel. Taking a proper radiograph pre-op, during the treatment, post-op, so that even the patients can look into the radiographs and they can understand what is going on inside. And if it is CBCT, it's much more understandable because it's three-dimensional. And even with pulp testing also, if most of the basic pulp testers are not available, then going for the very advanced methodology for diagnosis, when the basics are kept, or just the basic tools, just a mouth mirror explorer, the radiograph, which has proper exposure and all of the features, so that it's easy to diagnose, and pulp testing, be it just a cold test or an electric pulp test, that itself is sufficient. But additionally, a CBCT has, for me personally, it has been a very big help. Then even microscopes are very useful. I work under loops, not microscopes. So that has been very helpful even in detecting small cracks and understanding morphologies. So for working and for treatment purposes, all of these has been very helpful.
Okay, ma'am. While from your answer, I'm getting that it is very easy to diagnose and get treatment in this. Only the patient is delaying to seeking care.
Yes. We can easily, most of them, it is easier to diagnose.
Yes.
Like any other conditions, there can be this confusion that differential diagnosis can cause a little bit of issue. But still, when we use advancements like CBCT and microscopes, then most of the problems are solved.
Okay. Thank you, ma'am. And moving on to clinical management, what is the treatment we can take to preserve naturally our teeth?
Okay, so if it is not pulpily involved, there is no pain or no kind of irritation, then the minimum we can do is restorations. If there is any caries or even cracks are also there nowadays, there are treatments where we can conservatively manage. If that is not the case, if the caries has gone deeper, even before endodontic treatments, we should always be thinking about something called as vital pulp therapy. So we are trying to save the pulp. So depending upon the level of inflammation, so if it is just on the superficial layer, we would just do a direct pulp capping alone, or a partial. As it goes deeper, it would be a partial pulpotomy, or if it has reached almost the entire coronal pulp, then we can do a pulpotomy. And furthermore, if it is going to the root canals, then only I feel that root canal treatments should be, or this endodontic therapy has to be suggested. But generally, what do you say, the attempt towards pain or any mild discomfort is an endodontic treatment followed by crown placement. So this is a usual protocol which is best to preserve teeth, because even if after pulpotomy patient has pain, there is an option for us to do a root canal treatment, and only if that fails, we have to go for retreatment or extraction and implant, which is a last option. So these could be many ways in which teeth can be saved.
Yes, ma'am. And moving on to system level challenges, what are the challenges you are facing, and how you are coming across the challenges in treating patients, ma'am?
With patients, one thing I feel, with patients, making them understand, if it is, especially when it is conservative treatment, I feel patients are very, they have this hindrance to do that treatment. They feel that, okay, if I have pain, I'll do it. So after pain, they're ready to do endodontic treatment or even do an extraction and an implant placement. But conservative or preventive or these interceptive treatments are something it is difficult to communicate. I think with more and more education and all, this can be improved. And also, sometimes when the treatment is difficult or there is some kind of a morphological complexity, if it is like something like dense invaginatus, for example, it is not, normally we can't do the normal biomechanical preparation and obturation. There's a different protocol for doing that. So when we explain that, and when the treatment cost and the timing is explained, sometimes it does not reach across to the patients. So these are some of the challenges. And otherwise, if as a consultant, a challenge I face is this thing. Already I had mentioned the basic. Sometimes the basic pulp testers might not be available. So sometimes instead of going for an endodontic treatment, I can actually give a vital pulp therapy. But since these tools are not available, and I might not be carrying it all the time, so in those situations, it's a little difficult. In some places, the radiographs are also not. So that those are very minute challenges. So that's it. I think these are some challenges I've come across.
Thank you, ma'am. And moving on to clinical management, how does endodontic treatment influencing patients' outcomes, ma'am? What are the prognosis time, and how they are getting recovered? What are the time taking, and can you say about that, ma'am?
Yeah, definitely. So it's simple. If the patient comes at a stage when the disease is at the earliest stage, the treatment is also quick, the healing is better, the success is obviously is going to be better. But when for example, if it has moved from pulpitis and it has gone to a periradicular disease, automatically the success of treatment goes down. There are so many articles talking about this success of endodontic treatment, and especially when there is an abscess or a periapical cyst, all of this can compromise, and the treatment duration also can increase accordingly. And usually for non-vital teeth, the treatment is never a single visit endodontic treatment. Single visit endodontic treatment is something which is done frequently nowadays. So if it is non-vital teeth or the patient has a periapical lesion or a cyst, it is always safe that we go for 2 visits. So a 1 week gap of intra-radicular what do you say, medicaments are placed, and then it can be continued. So if it is a cyst, then it would go with a surgical intervention also. So it depends. It depends upon how the patient comes, what is the level of the disease they come with, and also it also depends upon the method of cleaning and shaping we do also. If we do it very quickly and get it done in few minutes, then the prognosis is going to get affected. And also on the patient's end, when they follow our instructions and do things as we instruct them after the appointment, then accordingly the treatment prognosis also is better in those individuals.
Yes. Okay, ma'am. Thank you. Thank you so much for this insightful interview. And from a public health perspective, I have one last question, ma'am. What change do you think can improve access to quality dental care, ma'am?
Quality, I think I personally feel instead of going for very advanced things, I think just basic communication and integrating a different group of individuals, doctors, and also having the basic tools for diagnosis and treatment would be enough. That when that layer of things are already good, I think then our treatment and all of that is going to be better, and that itself can improve a lot of things.
Yes, ma'am. From your perspective, as we public health students, we also read like that early diagnosis and treatment is always best. So patients should always seek health care before any problem occurs. So what are the
Mhm.
ways to prevent before occurring? What are the ways to prevent, ma'am, our teeth? Any simple tips?
Yeah, sure. One thing, see, as a dentist, we would know, right? If we have plaque or calculus, we'll know when we look in the mirror. But if it's for patients, then other than just looking in the mirror, they might not know about the lingual aspects of our teeth.
Yes,
All of that they can only get checked when we look into it.
yes, ma'am.
And also, as a dentist, we should know about this different, this staging of demineralization. Because patient, when they come with a white spot, we should be able to differentiate whether it's because of some kind of a fluorosis, or is it because of the caries is getting started in those areas. So we should also be in touch with these things, because I can only talk from an endodontic perspective about caries and all of that, since that is a large a problem for us, because caries and pain are. So I think that's the thing. Just looking into it, and we have tools to help. For example, there are caries detecting dyes available right now. Those are not very expensive. We can just buy it from the market and apply and see. Just like we use disclosing agents for the plaque, we can make the patient understand. See, this is what is happening here. It doesn't happen in normal teeth. Make them, educate them, and tell them, okay, it's in the beginning stages. We can do something about it. So I feel from our end also we'll have to learn certain things, keep up with what is going on, not just go for the higher ends like very advanced and very technologically advanced things, just simple things which are coming up in the market, and try to do things which is suitable for us also, and also understand what is going on. One main thing, if it is for patients, I feel it is regular checkups and to communicate with the dentist, and also improve. Now, I think knowledge is gained from everywhere. We have internet and chat GPT, so it's very easy if you even type it, they can get knowledge very easily. But educating them is from our end, so I think that would be.
Yeah, ma'am. Thank you, ma'am. Thank you for this insightful informations about endodontics. I will share this information to the general people and public, and I will create a health promotion and a health education to the common public through your video. Thank you so much, ma'am. And also,
Thank you,
it was a
thank you.
great learning experience as a public health student and also as a homeopath. And anything you would like to share at last, ma'am?
This is it. Like, basically, I just want to say, whatever resources you are already in a public health sector, to educate and spread the awareness. Even it's very less when it comes to medical and dental, the awareness generally is very neglected in our society. So that if you are able to do this and do that health promotion, it's a really great idea, and I'm encouraging you, and I'm always with this ideology.
Thank you, ma'am. Thank you so much for providing your time to us. Thank you so much for joining One Public Health. Thank you once again, ma'am.
Thank
Thank
you.
you.
Thank you.
Thank you, ma'am.
Thank you for having me. Thank you so much.
Thank you, ma'am.